We're going to start our pediatric examination with discussion of patient vitals. Just a few tips to get you started before we get into the examination. These are just a few key tips that I have for you guys. We're going to examine our patient head to toe. Now, the order of how you examine your child in your office is going to change. I kind of go with the more important things to evaluate first. That way, if I lose my window of opportunity where they're going to cooperate, then I've already at least gotten through the things I really need to. So that might be a direction that you want to go. You might also look at if the baby's asleep when they're in there. Do some of the examinations that need the baby to be quiet and relaxed. So maybe do your respiration, your heart and lung exam, maybe the abdomen exam at that point when you really have to listen and auscultate and perform those while the baby is resting and calm and quiet. Those might be some times to do that. So each visit, your flow may be completely different depending on how that patient is going to manage. But when you're first learning, you're probably going to want to go top to bottom on our order of our physical exam form, and that's fine if you want to do that. But just understand that you may need to alter your examination flow to fit how that child is for that particular day. So just be prepared to be flexible with your examination flow. Also, this is mostly going to be for adolescent patient, but maybe you've got a female teenager in your office and you're a male doc. You may want to bring your CA in, or at least have a door open or a parent close by in the examination room with you, and vice versa if it's male adolescent and female doc. A lot of the exam procedures that we're going to go through this week all can be performed on a parent lap or close by, to keep the baby and the child comfortable. So just keep that in mind as I walk you through these procedures. Think about ways that you can position the baby or the child to keep them comfortable with the parent. And the last thing I want you to be aware of is keep baby warm. Most of the time we're going to have baby down into their diaper during the exam, so we want to make sure that we're evaluating and observing all of their body. But I always suggest having the parent bring in a blanket with them to the visit. I also keep a couple blankets in my office. I always had a space heater underneath my desk so I can keep my hands warm, or just run them under some warm water before you begin. It's the last thing you want to do is shock a baby with your cold hands. They might not like that so well. So make sure that you're warm and that the baby's warm during the examination. We're going to focus going over all the vital signs for your pediatric patient. Now, most of these vital signs you take on adults you're comfortable with. We are going to add in head circumference with our list of vital signs for our pediatric patients. So we're going to walk through each one of these. Most of the information you already are familiar with, but I might go through some ways in how we perform these on our infants and small kids. For height of our kids, if the child is under age 2, or maybe they can't stand yet, whatever that might be, one of the best ways to measure height is just have them lay flat on your table. One of the tricks I have is that, we've got all this extra face paper. I rip off a big long sheet of that. I lay the baby down on top of it. I have the parent kind of help me with this. I'm going to have them hold the baby on the piece of paper on their back. I'm going to mark where their top of their head is, and then I'm going to gently extend their leg and dorsiflex their foot, so I mark the bottom of their heel on the piece of paper. Then I hand off the child, the baby, to mom or dad, and then I take my handy dandy little tape measure and then I measure my marks on my piece of paper. That way you're not having to wrestle that tape measure with the child laying down, or they're real wiggly or whatever it might be. You can just easily measure those marks on your piece of paper. But that is an easy way to assess length and height of a young infant, a young kid. Once they get older and they're weight bearing, they can kind of follow directions. You can use the regular ruler on the scale that we use in the clinic. So those would be the ways that you get the height there. As far as increase and decrease in height, most of the time this is due to family traits and different things. So, with growth charts, you don't necessarily have to keep track of growth charts in your office unless they're not going to their pediatrician for well child checkups. But most of the time, parents kind of know what percentile their child falls in as far as height. So they might say, oh yeah, my kid's in the 25th percentile on height. And so often they kind of know, my kid's kind of on the shorter end, or they're really tall for their age, or they're kind of right in the middle. And most of the time, if there is any concern, the pediatrician's also watching this during that time. So as far as weight goes, I'm going to recommend that with infants, to weigh them, you actually use an infant scale. And the reason I want you guys to use an infant scale is it's a lot more accurate than just having the parent hold the child and get on a standard scale. The infant scale is going to actually measure weight by pounds and ounces. And when they're young infants like that, we want to make sure that we're getting a real accurate weight on them. Once they're a little bit older, toddler age and up, you can use the regular scale that you have in your office. But as far as decreases and increases in weight, a lot of times it's going to look at what the child's eating or not eating. We could see a failure to thrive issue with our decrease in weight. So maybe they're not absorbing their food like they should. That might be an issue. You could also look to see if there's a possible thyroid or pituitary issue going on with that. And an increase in weight, most commonly you're going to see it be the baby's being overfed, or they've got a poor diet, they're not exercising right. But you might also see some other genetic issues that come along. So Prader Villi might be something that you could consider with this as a condition. So what happens with kiddos that have this condition is that they'll really start off with a slow weight gain. They'll have a lot of low muscle tone at this point. They often have some other physical characteristics of them. So they'll have a narrow forehead, maybe some almond-shaped eyes, downturned mouth. But what'll happen is that they have, after that first year, then they turn into having some really increased hunger, and they start to gain weight really quickly after that. So those might be some genetic things to consider when we're looking at weight changes and weight gain after that. So maybe really low when they were a baby, and then all of a sudden they just gain a lot of weight. So, if you're seeing a lot of those drastic changes, it may be worth some lab work and further evaluation to see if there isn't something else underlying going on. Head circumference is one of the vitals that you probably aren't as familiar with or as comfortable with performing. This is going to be really important to measure up into age 2. Some resources and docs will measure head circumference up to age 3. So you could go either 2 or 3, but most commonly you'll see it measured routinely up to age 2. What you're going to do is you're going to take your flexible tape measure and you're going to measure around the EOP to the most prominent part on the forehead of the baby. This is another one that might be a little hard to do on a wiggly kid, so you may have to get the parent to kind of help you perform this. But the major things I want you to understand and why we need to measure head circumference, this is a really important vital to measure. So if you don't get anything, get height, weight, and head circumference. Those are some big ones to measure in these first few years of life. So one of the things to think about with head circumference is that it actually reflects the rate of brain growth. So an interesting fact is that about half of your brain growth is actually completed by 9 months. So that's why we kind of see babies have kind of a bigger head compared to the size of their body. Because there's a lot of brain growth happening at this point. So their head grows during this time. So half your brain growth is done by 9 months. And then by age 2, 75% of it's completed at that time. So part of why we're measuring this is just to make sure that the brain is growing like it should. So part of the concern is if we are tracking these measurements and all of a sudden maybe we see that their head circumference kind of plateaus or decreases compared to the fact that it was increasing, or vice versa, those might be some reason to be concerned. So we could have macrocephaly where our head circumference is increasing. This could be related to some kind of intracranial pressure or hydrocephalus presentation. a decrease in head circumference, maybe if it's just slow growth or it just kind of falls off those growth charts, we might be dealing with a microcephaly. And often in these cases, that is a congenital chromosomal disorder. But it could also come from any kind of trauma, infection, substance abuse from mom during pregnancy. So there could be a lot of reasons why that happens. So again, a really important vital to make sure that we're checking on our kiddos. This is just to give you a little bit of reference on what normal newborn averages are. I'm not going to expect you to memorize these numbers or anything, but I do want you to be aware of what kind of the normal weight of a newborn, normal length of a newborn is, and what their head circumference is, just so you've got a reference for that. Blood pressure is a tricky vital to get on babies and young kids. It's not one that I really stress out about if I don't get, especially if I'm not concerned with any other underlying issues. So don't worry too much if you can't get this or you're having trouble with it. One of my biggest tips for you guys is, one, make sure that you have the proper size cuff. So they make infant and pediatric size blood pressure cuffs. So make sure you get the proper size, and it should cover at least 80% of the extremity that you're trying to test. So if it's on the arm, we want to make sure it's covering 80% of that bicep area. If the cuff is too narrow, it'll actually make the blood pressure increase. And if it's too wide, it will lower your rate. So we want to make sure that that number is accurate. Other tips I have for you is that I would save this for the very end of your exam. This is going to be pretty uncomfortable for your child or the infant, so I would wait until the end to test this vital, just especially if you're not really concerned about the baby's overall health and this isn't one of the issues that you think is going on. I would save this vital for the end because it's going to be fairly irritating to that child. So you don't want to start your visit off with the baby already crying. So start with kind of some of the gentler, non-invasive things, and then work your way up to some of the things that might irritate them. Also, I never try more than 2 times. So if you're checking the blood pressure and you've attempted 2 times to check it and you're still having trouble, just be done. And then don't pump up the cuff too high. So we're going to find out here in just a minute that our blood pressures for our babies are really low compared to what adults are. And so you don't need to pump up your blood pressure cuff to 160 to start it. So, maybe go up to 110 max to see where they're at with that. So just be really careful doing blood pressure, and don't get too frustrated if you can't get it done, because it is very difficult on babies and young kids. Just a little bit of information, if you are seeing cases where the child or the infant has high blood pressure, often it's a secondary type hypertension related to some kind of kidney or renal congenital abnormality. So we want to make sure that those aren't in the history, and that if you are experiencing a child with high blood pressure, that you do refer them out, because there may be something underlying going on that they may not know yet. This is just a chart to show you some of the normal values of blood pressure in infants, toddlers, school age, and then older kids. So you can see in our infants that their systolic blood pressure is quite low, and as well as their diastolic. So it's not uncommon to see a fairly low blood pressure in our young babies. So don't freak out if you're seeing, an 85/60 blood pressure in an infant. That is still falling within normal parameters of those vitals. And then as they get older, you're going to start to see that they get closer to an adult rate. Heart rate is one of those vitals and examination procedures that I recommend that you maybe do first, or while the child is nice and calm, or maybe even sleeping. You're going to get a more accurate heart rate if the baby is nice and relaxed. So you may want to do this right off the bat. Just remember that if baby is running a fever, so that can impact heart rate. So with every degree temperature increase centigrade, you're going to see an increase in 10 beats per minute of their heart rate. So just keep that in mind. If baby is coming with a fever, you're going to see that heart rate be even a little bit higher than it should be. Just kind of a normal part of how the body works with that. When you're taking the heart rate, radial pulse probably isn't going to be the best place to check on an infant. Brachial pulse is going to be a better location to take that heart rate at, as well as your femoral pulse. So those would be areas that I would go check heart rate if I'm going to palpate for heart rate. One of the ways that I find the easiest to check heart rate is when you're auscultating the heart. Just auscultate the heart rate right there. So you can get out your stopwatch or your watch and count with that. It's a lot easier to hear and over trying to feel on a wiggly baby their actual heart rate. So you can also auscultate that heart rate, which is a much easier way to do that. Another chart for you guys to see the normal rates of heart rate based off infant to adolescent, and you're going to see that infants tend to have a pretty high heart rate, so don't freak out if it's going really fast. It is common to see that, and again, if they've got a fever, you're going to see that go even higher. So it can get a little scary, but do understand that heart rate is fairly high in infancy, and then kind of slows down more adult level as they get into adolescent. Respiration is another one that's kind of difficult to see and assess in babies, and so that's another one that I recommend that you do if they are resting and calm. You do this right away at the beginning of the exam. With respiration, the main thing I want you to really focus on is, watching them breathe. Are they showing any increase in effort while they're breathing? This could look in the form as retraction in their ribs. So what'll happen if they're having trouble breathing, you'll actually see more of their rib cage. The tissue between the ribs will actually depress in, and you'll actually see some retraction with that. So that would be a sign that they're having some issues breathing. Also, an increase in rate, again, would be part of that. Nostril flaring is another common one. They're really using their neck muscles and chest to really breathe better with that. So when you are checking respiration rate, look at the rate, the rhythm, the depth, how much effort they're looking at with that. Another thing to note in newborns, and something that a lot of new parents freak out about, I did the same thing, is that some newborn babies will actually have a pause in breathing. It's not uncommon to see this thing called a periodic breathing, where an infant will actually kind of hold their breath for 10 seconds and then breathe again. That's fairly normal in a newborn state, as they're just trying to learn how to breathe and kind of be in this world, and their body starts to regulate. You might see that, but anything over that would be concerning and needs a referral. This is a video of Connor when he was an infant, and you can see normal breathing with a baby. So with the breathing pattern on a baby, what you'll see is that they're mostly abdominal breathers instead of chest breathers. And so as they kind of get around the age of 7 or so, they'll start to use their chest more with that. But you are going to often see babies' belly rise a lot more when they're breathing as an infant. One of the easy ways that you can check respiration rate is watching the belly move up and down. It's kind of hard to sit there and watch their chest expand, like we kind of do with adults, but you could watch the belly move up and down to help with rate. You can also put the stethoscope under their nose to check that. Those would be some tips on how to get a good, accurate respiratory rate. And here's your chart just to show you the kind of normal rates. So again, infants breathe a lot faster per minute versus adolescents. So you're going to see that they're going to breathe anywhere from 30 to 55 breaths per minute. Again, anything over that or just showing more effort would be cause for concern with their breathing pattern. The last vital we're going to discuss is temperature. This should be a vital that you definitely take on your pediatric patients when they come in. Just different things that can cause an increased temperature. Probably most common would be some kind of infection. Sometimes you'll see this after increased activity too. So if they're coming in and they look well, were they running around your parking lot or in the hallways before they came into your room before you did their temperature? So there could be some other underlying things going on with an increase in temperature. So please make sure that you take that into consideration. Decrease, we could see, hypothyroidism, shock, medications can do it. Infections in newborns is not uncommon to see actually a decrease. So we want to make sure that we're checking temperature on our babies and kids. These are just some normal values of temperature and what we can expect as far as what we do. Now, how you take the temperature will determine the range of normal. So if you're going to take an axillary temperature, you can see that the upper range of normal is 99.1 versus if you take it in the ear, rectally, or even a temporal type temperature, those are going to be 100.4. So just understand that if you are going to take axillary, that it's going to be a little less than some of your other methods as far as if they're considered to have a fever or not. So just be aware of that because that can change based on how you check it. Just a few things on accuracy of temperature. So your most and best accurate way to test temperature is actually rectal temperature. That's going to give you your most accurate method. You can also use one of those temporal artery thermometers. They are also considered to be close to the same accuracy as the rectal temperature check. Your least accurate is going to be the axillary, but if that's the only method you've got in your office, then that's still fine. Just again, remember that the rates and the measurement of that is going to be a little different than your rectal temperature. Also, depending on the age of your child, can also determine the best way to check temperature as well. So if they're under 3, I prefer the axillary. They can't really hold it in their mouth for an oral. Rectal temperature, I don't recommend you doing that in your office. Now, I've had to do it a couple times just to verify my findings. So sometimes if my axillary temperature is strangely high, or some other method I'm using just doesn't seem right, I might check the rectal temperature just to verify, because that again is your most accurate. But it's not my go-to method. But I often use the axillary temperature on young infants. That's okay, but it's not the most accurate. Now, when they get a little bit older, you can do, they have pacifier thermometers, which are really cool. And then, of course, you've got your temporal or ear thermometers that can also be used on those. So older kids, at that point, they can probably do an oral thermometer because they can follow directions and hold that in there, or any of the other methods provided.